another of Bahama Health's Doc Talks. We are celebrating Cancer Month, and we thank our viewing audience for coming on. Bahama Health takes a pleasure in sharing with our policyholders and the wider community on such an important topic. And on behalf of the management and staff of Bahama Health and Family Guardian, we say welcome again to our series. And so to get us started, we do have some prizes, and we are looking for some survivors who may be tuned in this evening. So if you're a 5-year survivor of cancer, would you just open your mic, give us your name, and you can then just type your address in. Do we have any 5-year cancer survivors on?
Yes, you do, Shamin Cornish.
Oh, President Cornish. Wow, great. Nice to have you. Okay, so please just type your address in and we will contact you for a prize. Okay, do we have another 5-year survivor on? Do we have another 5-year survivor, cancer survivor?
Yeah. Just trying to click myself in, Pamela.
Okay, we'll give you a moment, Pamela. And please, if you want to open your cameras, we'd like to see you.
Oh, okay.
Okay, Pamela. If you can, in those corners, you can, we can see. So that's okay. So we have 2 5-year survivors. What about 10? Do we have a 10-year? Do we have any 10-year survivors on? No one 10. What about 15?
Helen Rose 17. Yes.
Hi, my name is Ethel Johnson.
Hi, Miss J.
Hi. How are you, Ms.
I'm great.
Good, very good. Yes, I am a 15-year survivor.
Oh, wow.
Yes,
Isn't this awesome? Isn't this awesome?
Yes, ma'am.
Okay, we have a lot to be grateful for. And there was a Helen as well. Helen, you're saying you're 17, but just for, coming in, we'd get a prize as well. Please put your telephone contact in the chat and we would have prizes going out. Okay, so we did 15, we got 17. Do we have a 20-year survivor on? Do we have anyone who would have survived 20 years? Okay, if you are a survivor and you've been on for more than 20 years, I guess you can also identify yourself. Okay, well, if not, we are grateful. Oh, Helen, is it Helen? You're saying something?
Yes, I'm trying to put my name in.
Okay. All right. Okay, so once you can get your address, and so we do, once you have placed your name and telephone number, we will contact you. So thank you, and this is a great testament to show that, there are survivors who are around. So thank you for tuning in to Bahama Health. So without further ado, we're going to ask Nurse Marisha Charlton to come and introduce our speakers for this evening. Nurse Charlton?
Yes, good afternoon, everyone. Welcome, and thank you again for joining us. I have the pleasure of introducing our panelists for this afternoon. Dr. Munroe completed her undergraduate degree in medicine at the University of the West Indies, Kingston, Jamaica. She completed postgraduate training in radiation oncology at the University of Alberta in Alberta, Canada. Palliative care at the University of Dundee, pain management at the University of South Wales, and that is Wales, United Kingdom as well. Dr. Margo Munroe conducts weekly clinics in radiation oncology, palliative care, and pain management. Ladies and gentlemen, Dr. Margo Munroe.
Hello, good evening. Thanks for the opportunity to be here with you, ladies and gents.
Hello, Dr. Munroe, welcome.
So I've been given the opportunity to discuss male breast cancer. This is not a very common type of cancer. And the first thing we want to start off with is an understanding of the fact that men do have a small amount of breast tissue. And this is located under the nipple and that darkened area known as the areola. And it does consist of a small amount of breast tissue with a few ducts. And the ducts are what transports the milk that's produced to the nipples, and the lobules. These are the glands that actually produce the milk. In males, the breast tissue does not grow very much, and that's primarily because men have very low levels of estrogen, the female hormones. And this is really what's in part responsible for the development of breast tissue. Now, male breast cancer, MBC, is rare, and it's due to abnormal cell growth. The cause of male breast cancer is currently unknown. And the reality is that it can arise from from different parts of the breast itself. So when it arises from the ducts, if it's contained within the duct, it's known as ductal carcinoma in situ. If it breaches the duct, it's known as invasive ductal carcinoma. And the ductal carcinoma is the most common type of male breast cancer. Because men have very few lobules, that's the glands that actually produce milk, there's some studies that would suggest that men do not develop lobular breast cancer. Other papers would suggest that if in fact they do, it's extremely rare. Another type of cancer that men can develop is Paget's disease of the nipple. And really what this is a cancer that's developed in the duct and spread onto the nipple. There are very, very, very many reasons why men would typically present late. And this can be due to a number of reasons. One, a lack of awareness in the general public that men can in fact do develop breast cancer, and for some clinicians that are not oncologists as well. There is a lack of public education to this reality that men do in fact develop breast cancer. And of course, most of the media, digital and print, is really geared to women and not men. So there isn't a prolific source of data in terms of material in the media that you see speaking or addressing this question of male breast cancer. And of course, for most men, it would be considered an embarrassment to even discuss it or suggest it. And so these are some of the reasons why men will typically present late. The other component of it is, surprisingly or not so surprisingly, a number of men don't have a good psychosocial or emotional support network, whether that's within the home or outside of the home. And so the comfort they have discussing a lump or any abnormality of the breast is also going to be a factor why they're going to present late. And as a result of presenting late, men typically present with advanced disease and advanced diseases often result in poor prognosis. Now, there are a number of different symptoms that men will notice or may notice if they have breast cancer. And these symptoms are in part similar to what women experience. The only difference is for men, the lump that presents is typically painless. It can present as a swelling or just a simple thickening in the breast. The breast skin itself can show evidence of dimpling, irritation, puckering, redness, or some degree of scaliness or dryness. They may or may not notice a nipple discharge, pain involving the nipple, redness, scaliness of the nipple, or they may notice that the nipple is pulled in or pushed off to the side. If it's pulled in, we typically say that this is a retracted or inverted nipple. In some cases, men may in fact present with a swelling or several swelling or lumps in the armpit. Now, this is I thought this was a very informative graphic explaining the different symptoms that may indicate that an individual has a breast lump. And essentially what this slide shows or demonstrates are all the previous symptoms that were mentioned. So let's move on to discussing the risk factors that may be associated with male breast cancer. Age, or the whole process of aging. So most breast cancers occur after the age of 50. There may be genetic mutations, such as the Bracha gene, more commonly in males, which may be associated with breast cancer, pancreatic cancer, as well as prostate cancer. If there is a family history of breast cancer, and in particular, first-degree relatives within that family, and we're talking about female relatives. If there's a history of liver disease, and the liver disease may be associated to excessive alcohol consumption, it may be associated with chronic hepatitis. What can happen is the liver becomes scarred or cirrhotic, and as a result of this, higher levels of estrogen is produced in the male body. Obesity and being overweight can also be considered a risk factor. Testicular injury or surgery has also been implicated as a risk factor. And then there's this genetic mutation, Klinefelter syndrome. And in this syndrome, men have an extra X chromosome. And this syndrome is associated with higher levels of estrogen. Radiotherapy or radiation treatments under the age of 30 in males, especially during adolescence, when their anterior chest wall may be treated if they've had a childhood malignancy. And then hormone therapy. In the case of prostate cancer, males may be placed on hormonal therapy. They may be on an intermittent course of hormonal therapy, a short course of hormonal therapy lasting 1 to 3 months, or they may be on an extended course of radiotherapy, hormonal therapy lasting 2 to 3 years. In treating prostate cancer, placing the males on a hormonal therapy lowers the testosterone levels, but it also allows for the female hormone present in the male body to achieve higher levels. So these are the risk factors, or some of the risk factors that have been associated with males developing breast cancer. This is once again another very informative slide that graphically represents or depicts some of those risk factors. So the heavy alcohol use, the BRCA2 gene mutation, the aging, chronic liver disease, hereditary factors, as well as excess body weight. One of the other things of note on this slide is the fact that breast cancer is thought to be 100 times less common among men than among women. And so typically you may hear people say, a man's risk of developing breast cancer is 1 in 1,000. Now, interestingly enough, January of this year, 2021, the American Cancer Society has adjusted that figure, and it's now 1 in 833. So what that means is, even though male breast cancers are rare, there appears to be a slight increase noted. Now, how do we diagnose male breast cancer? Very similar to what we currently do for females who have a lump in their breast. And so we use a number of imaging tools: ultrasounds, mammograms, CT scans, MRIs, and PET CTs. All of these imaging tools may or can be used to try and, 1, confirm that there's a mass, 2, used to help determine the stage of the cancer. Once a mass has been identified, it is going to be imaged, followed by a biopsy. Now, that can be a core needle biopsy, or it can be an excisional biopsy, where the mass is completely removed with a rim of normal, healthy tissue. And this tissue is then sent to the pathologist, where it will be analyzed. And once it has been analyzed and confirmed to be a breast cancer, then additional studies are going to be done on that tissue. And one of those studies is going to be a need to determine the hormonal status, whether the cancer that's present is estrogen positive, progesterone positive, or the HER2 mu status of the cancer. Now, all of this information will be used to ultimately determine how to treat the patient. As with other cancers, the patient is going to have to be staged, and there are 4 stages. Well, typically we say DCIS, which is ductal carcinoma in situ, is stage 0. Once the cancer has broken through the duct into the surrounding fatty breast tissue, we then begin to stage it: stage 1, stage 2, stage 3, and stage 4. Stage 1 and 2 are considered early stage diseases. Stage 3 and 4 are considered more advanced stages, with stage 4 meaning that the cancer has moved from the primary site in the breast to a distant site removed from the breast. And that can be lung, bone, liver, brain. Now, how do we go about treating male breast cancers? The truth is, because the numbers are so small, 1, and 2, there aren't very many clinical trials being done on male breast cancer patients. For the most part, male breast cancers are treated similar to female breast cancers. So in terms of oncological interventions, the first thing that's going to be done after the biopsy is a determination is going to be made as to whether the patient is going to have breast conserving surgery, which means the tumor with a surrounding area of normal tissue is removed, or whether the patient is going to have modified radical mastectomy, which is going to involve removal of all the breast tissue, and axillary or sentinel lymph node dissection. Now, the surgery is going to help determine a number of things after pathological examination. The size, whether the tumor, the cancer has been completely removed by the surgery, whether there have been lymph nodes involved, meaning that the lymph node in the breast has started spreading to the lymph nodes in the armpit and the lymph node area behind the collarbone on the affected side. So the surgical intervention can be both and is often both diagnostic as well as therapeutic. The next oncological intervention to be considered would be systemic therapy. And under systemic therapy, most people just tend to assume chemotherapy is the only thing. But under the umbrella of systemic therapy, there is chemotherapy, endocrine therapy, targeted therapy, and immunotherapy. And the other major oncological intervention in the management of male breast cancer is radiotherapy. And there are a number of different ways of delivering radiation treatments. 3D conformal radiotherapy, IMRT, which is a very elegant way of targeting the area in the body that needs to receive radiation, and also at the same time minimizing the associated side effects. And IORT is intraoperative radiotherapy, and that is something that's currently being explored and is not available outside of a clinical, not a clinical trial, outside of a teaching hospital. So the next slide shows what lumpectomy and a partial mastectomy looks like. So with respect to lumpectomy, and both of these fall under breast conserving surgery. The tumor plus a ring of normal healthy tissue is removed. With a partial mastectomy, a larger area of normal tissue is removed and lymph nodes in the armpit are sampled. For male breast cancer, mastectomy involves removal of the breast tissue, inclusive of that pectoralis muscle, as well as sampling the lymph nodes in the armpit. So it's a larger or more extensive surgical procedure. Radiation treatments are delivered typically by a LINAC, which is a linear accelerator that generates high energy electrodes as well as photons, a type of energy that can then be targeted through the head of this machine at a specific area of the body. this was I thought would be a very helpful tool to make available to males and females, because women are actually, or can be, very influential in getting the men in their lives to become more aware of breast cancer. Typically, you would see a card like this for women, but there are several sites that have developed that are catering specifically to men with breast cancer. And it gives details on how a man can examine himself. And self-breast examinations for men is recommended monthly, as is for women. These are the references to a number of tools that I've presented during the discussion. And the last reference, actually, if you click on it, it will take you to the site on YouTube where a male is demonstrating how to correctly do the breast exam. Thank you very much. And I believe questions are going to be at the end, if I'm not mistaken.
Yes.
Our second panelist is Dr. Locksley Munroe. Dr. Munroe was born and grew up in Duncanstown, Ragged Island. He was accepted into Government High School in 1968, the University of West Indies, Mona, Kingston in 1975, and the Faculty of Medical Science in 1976. Graduating medical school in 1982, Munroe became the first person originating from Ragged Island to become a doctor. Having served 5 years bond to the Bahamas government, he returned to the University of West Indies for postgraduate training in DM surgery, being the first Bahamian surgeon to complete the program in 1992. In 1994, through SLS and Professor Helm, he was trained in minimal invasive surgery in Ohio, becoming the first Bahamian-based surgeon to perform a laparoscopic cholecystectomy at the Princess Margaret Hospital. Dr. Locksley Munroe has won many prizes, including the Noel Hayes Prize for Anatomy and Chin Yee's Prize for Surgical Essay on Adhesions. He is one of the co-founders of the NGO Sister Breast Cancer Support, has sat on a number of statutory boards, HHFLB, BMC, and has held the position of Director of the Operating Theater at Princess Margaret Hospital, as well as Head of Department of Surgery at PMH. Dr. Munroe is married to Marjorie Hernandez of Belize since 1981 and has 2 children. Without further ado, I present to you Dr. Locksley Munroe.
Good afternoon, all, and to Ms. Charlene. Once again, thank you for your invitation to make this presentation. She asked me to speak about female breast cancer or breast cancer in general, and primarily about early detection. What are the symptoms and how do you approach the management or the treatment of breast cancer? So from a medical standpoint, early detection is what we call screening. Symptoms, as you will know, you have some symptoms, but cancers on the whole tend to be asymptomatic in their early phase. And the treatment, you have multiple modalities and multiple disciplines involved in the management and the treatment of breast cancers. Awareness and the seriousness of this disease was well known for a long time. There was a surgeon in Spain, an Arabic guy who came out of the East in the Ottoman Empire, Zawahiri, 936 to 1013. And he made the statement in the early 11th century, once breast cancer is out with the breast, it is no longer curable. That was true in his day because in those days, the only option was surgery. But today, the concept has advanced, not so much to cure alone, but for control of the disease. Can you cure it, or are you going to be able to control it? So what do we do for screening? And Dr. Margo actually mentioned some of these things. Screening tests have certain characteristics. They should be safe, they should be sensitive, they should be specific, and I guess the insurance company would like to hear that they should be cheap, available, and accessible to all. But screening tests are only a part of what is necessary in the management of breast cancer. Screening tests are part of a system because once you are detected, then there should be a method to deal with the problem that is found. And you require a certain amount of efficiency in a system to be able to deal with such things. Well, again, Dr. Margo mentioned this. Early detection or screening, you should know your body. That's breast self-examination. And the same organization she mentioned, the American Cancer Society, they are indicating that maybe breast self-examination is not so important. But I would like to say to all my Bahamian women, please learn to examine your breasts. That's in America. We are in the Bahamas. Okay, so literally, the simplest technique that you can use is your breast self-examination. She did indicate how that is to be done, particularly in the male, very similar in the female, that you should do it. Actually, I usually say to persons to do it every day until you get to know your breast. And then once you get to know your breast, then you may examine it possibly once per month, preferably just after you've seen your menstrual flow. That is when the breast is probably at its softest and it's easier then to detect any changes that may have taken place in the breast. Of course, the doctor needs to examine you. And again, you need your imaging, mammogram, ultrasounds, MRIs, magnetic resonance imaging. They have something called a thermogram and PET CT, another ways to screen the breast. And this screening doesn't take place before you get a cancer. These are methods to screen your breast even after the diagnosis, because you would like to know whether or not the cancer is returning. So screening is used before or after your diagnosis. And again, to give you an anatomy lesson, the breast in human beings develop from literally from the armpit down to the groin. That's where the mammary ridge is. But in human beings, you can actually, it atrophies or disappears in the lower region. But there are some women who have extra nipples and have extra breast tissue in their armpit. But this is the area where your breast tissue may be found. And again, as Dr. Munroe mentioned, your breast is sitting on top of your muscle, your pectoralis muscle. It consists of glands and fat. You have a nipple and an areola. So you have to learn these different areas of the breast. Again, just to give you an idea of what it looks like, it sits on top of your muscles and on your rib cage. It has the nipple, the areola, and these are the glands, and that's what we call the parenchyma. That's usually made up of fat if you're not pregnant. That's normal. Again, just to give you some idea of the blood supply and the lymphatics, because these become important when we consider breast cancer or any cancer, which determines the method by which that cancer may spread. Now, for your breast self-examination or for breast examination, these are the sort of positions that you have to hold when that physician is examining you. You sit, you put your hand up because you want to see whether or not there's any attachment or tethering. Sitting here, you can look at the skin, you can look at the nipple, as she mentioned. The nipple is inverted or retracted. The skin, you have what we call peau d'orange, which is French for the skin of an orange. So that's sitting up. So you're standing in front of your mirror and you're looking at your breast to see if there's any changes. When you're lying down, place your hand behind your head so that the breast is flattened out on your chest. You want to examine it in a systematic manner. Of course, if the doctor have to examine it, one of the important places where you're going to be examining is in the axilla, in the armpit, because you wish to find out if there are any lymph nodes. So when you've completed your history and physical, you may require imaging. And this is an old mammogram machine. They look different from this nowadays, but literally it's simply a machine that is going to allow you to pass x-rays through the breast in 2 different directions. And it'll give you pictures. And this is what we call a mammogram. That's the machine. This is the picture itself. And if you look at this picture, you'll see that there is some mass, lesion, lump. You got a tumor in the breast that is irregular. And what the radiologist would say is it is spiculated. And that's looking at the breast laterally. And in this here, you can see what looks to be some calcification. So these are all things that you look for when you are screening for breast cancer. So you've done your breast self-examination, you've seen your doctor, you've gotten your mammogram, and you have a lump, a mass, or a lesion, or a tumor. And we use all these words. Really and truly, it speaks to the same pathology. You could have a lump, you could have a mass, a lesion, a tumor, and anomaly. The real question is this a benign or malignant lesion? And here's where it's going to get a bit complicated. If you look at this, you're looking at what they call stem cells. These cells have the capacity to become just about anything in your body. Bone cells, cartilage, your muscle cells, all of these things can come from a stem cell. Okay, so cells start off as very basic, and then they differentiate into these end products. Again, this one just is showing you what happens with the skin. You start off with your basal cells, you get your granulocytes, then you get your squames. You see how this have a layer as well, and then these are your squames. So this is the normal differentiation of cells. And if you look at these all look exactly the same. This cell look exactly like that one. This look exactly the same. So they are just one set of cells that are differentiating into the skin. And this is, again, relatively complicated, but this is what we call the cell cycle. That the cells are in G0, they're at rest. They go into G1, they synthesize the DNA, they grow again, and then they actually divide and form 2 cells. So this is the cell cycle, important because that is what that skin development is showing you. And this cycle is what is used to a large extent by the medical oncologist to treat your cancer, because cancers tend to be dividing very rapidly. They are in that S phase, so you're able to attack them by using medication that interfere with the ability of the cancer cells to divide, to form the DNA and then to divide. So you will have your adriamycin, and then you'll have your Taxol, which kind of stop them from dividing. So this cell cycle is an important concept. You understand why it is or how it is that your chemotherapy is going to work. When you develop a cancer, it means that that normal process is out of control. What is it that causes loss of control? Obviously, as we say in medicine, you have congenital or acquired causes. And for breast cancer, one of the commonest causes is alteration in your Bracha gene. The Bracha gene, the BRCA gene, breast cancer gene, produces a protein that maintains your DNA. When that protein, when that gene has mutated, it doesn't produce an efficient protein, and therefore it does not repair your DNA as it ought to. And the DNA, in becoming abnormal, now cause the development of a cancer because the cells can no longer differentiate to where they're supposed to be. And obviously in the environment, you have all sorts of chemical agents. You have radiation that can cause cancer to develop. And here's what happened. Here you have a normal lining, and then you have a benign tumor, and you see those cells look different from the normal ones. And then you have a malignancy because those cells are now invading below what we call the basement membrane. And again, if you listen to the doctor, they'll talk about malignancy, they'll talk about cancers, they'll talk about sarcomas, then they'll talk about blood cancers. But really, the base word is malignancy. You want to know whether your lump is benign or malignant. And a malignancy can be a cancer or a sarcoma. Cancers come from the lining of organs or your skin. Sarcomas come from the soft tissue, from the fat or the bone. And obviously the blood is a slightly different thing because that's a liquid, it's not solid. The point I would like to make, particularly that differentiation, any cancer consists of clones of cells. Unlike when you look at that skin, where all those cells look exactly the same, in any cancer, there are different clones of cells because they are not differentiating or maturing in the manner in which they ought to. So you have a 1-year-old, you have a 3-year-old, you have a 7-year-old, you have an 18-year-old, and they're all forming that one tumor mass or lesion. And the sensitivity of your 18-year-old is different from that of your 12-year-old, different from that of your 1-year-old. And again, that has implication for how you're going to treat the patients. And also it has implication for when you get recurrence or progression of disease, because your chemotherapy may be able to knock out the 1-year-old, the 5-year-old, the 7-year-old, but that 18-year-old or the 19-year-old, that is a very tough young person. So they don't respond to your chemotherapy. And therefore, that implies that you require more than one type of medication, you require more than one type of treatment, and also that you may end up with recurrence, not because of failure of the treatment, but because your tumor does not consist of only one type of cell. And that's basically what this slide is about. That polyclonal nature has generated a new approach. You profile the tumor, explain to the patient the number of clones, you treat the dominant clones with classical chemotherapy. You can then use targeted therapy. Don't be surprised if you get recurrence. When it happens, don't be in shock. Walk into the battle again. symptoms are not very common with cancers on the whole. They're very silent. Your body basically accommodates them until it cannot do that anymore. And then you're going to see the tumor. You may find a lump. If it's colon, it'll be something different. If it's uterine, it's ovarian, it'll be something different. In the breast, you'll find a lump. You may find a nipple discharge. You may get some pain. Sometimes women form abscesses in their breast. And when if you're not lactating, we biopsy that. And you're shocked sometimes that it comes back showing that there is a cancer there. The breast may be asymmetric. You can see skin changes and you can find lumps in the axilla. The one thing again, and this sounds really technical, Complexion growth. What that means is that the tumor has grown, the rate of turnover is 75% greater than when you can actually find it. So that tumor is very active even before you can see it or feel it. In the clinical phase, it's only going at 25%. So that thing has been there for a while before we even find it. And that's why screening is important. And you have to understand it's growing somewhat slower when we have found it. The tumor will double in size after 15 to 20 turnover time. It becomes about the size of a pigeon pea. And by the time you found it, even though you may think it's a stage 1, and this is where the PET CT and the MRI comes in, 10 to 15% of stage 1s have actually already metastasized. And again, as mentioned, those things can spread to a number of different places. Beneath your arm, into the chest, into the lungs, above the collarbone, to the brain, to the liver, to the bones, to the pelvis. So those are all places where those breast cancer in particular can spread. And this is how they look sometimes. If you look here, you can see this lady has a lump right here in her breast, what we call the upper inner quadrant. You can actually see it. Unlike on the mammogram, where it's just showing up on the x-ray, in this case, you can see the lump right here on her breast. Here you have someone again with asymmetric breast. Why would you want to wait this long before you present yourself to the doctor? And we have something called Kubler-Ross. It's called denial. People they deny. I'm not claiming this, but the tumor is claiming you. You need to deal with it. Then they become angry. Why me? Why not them other people? Okay, so you have different phases of grief. And it's very important, again, as Dr. Munroe mentioned, to have that social support that gives you the confidence to be able to deal with this once it has happened. You don't want to tell anybody about this, but this is so obviously different from what you were before. And then I think like the last time I forewarned you that you're going to see something that is pretty gross. And these are the type of pictures you sometimes see. Patients present at this stage with cancers. Now, what is the doctor supposed to do? What am I supposed to do? You can imagine how this thing actually smells, okay? What are your treatment options? You have surgery, you have hormonal treatment, you have radiotherapy, you have chemotherapy. All of these have limitation. And I can tell you, treating breast cancer is a very expensive undertaking. Anywhere from $100,000 to $150,000, and you have to come up with that within 9 months if you want to get the proper treatment. Okay, so all these treatments have limitations. How do you address them? Primarily, you combine the treatment. They're not exclusive. So I took surgery, I don't need chemotherapy. I took hormonal therapy, I don't need to take any kind of radiotherapy. No. Each one is considered on the basis of the information available, and primarily you're talking about the staging. And again, as Dr. Margo mentioned, you got stage 1 and 2, where traditionally surgery is the mainstay. Chemotherapy is adjuvant. If you have stage 2, stage 3 or 4, then chemotherapy is the mainstay and surgery is adjuvant. So your treatment is going to depend on your stage of disease. And again, from a historical standpoint, this is Dr. Sawari. If breast cancer is outside the breast, it is incurable. In other words, if you can't remove the breast with all that tumor, if it's under the arm, that is no longer curable. That was true at his time, when surgery was primarily the only option. In today's world, we talk about cure versus control. How long can we control this disease for? We may be able to cure it, but remember what I said as well, that even stage 1, 10 to 15% of them already have mets by the time you make that diagnosis. That's basically the type of incision we make if you're doing a modified radical mastectomy. Radical mastectomy, French surgeon in the 1700s actually did the first set. Halsted in 1882 to 1895, up to 1970. Literally, he was the one who talked about extended radical mastectomy, which was a very, very morbid operation. In 1895, Dr. Bateson actually did the first oophorectomy in 3 young women, and he had a good response. And of course, they pushed the operation to oophorectomy, adrenalectomy, hypophosectomy, that's in the brain. And these things were almost as bad as doing the extended modified radical mastectomy, but it let you know that hormones played a role in your options for treatment. Radiotherapy, again, from a historical standpoint, Dr. Munroe mentioned radiation treatment. It was discovered in 1852. Madame Curie actually was the one who developed quite a bit of radiation equipment, radiology equipment. Röntgen discovered X-rays in 1895, and then the first set of doctors to use it in breast cancer treatment was Dr. Keynes in 1937. And Moynihan made the statement, why abuse a woman with a radical mastectomy when radiotherapy gives the same result with much less morbidity? Of course, if you present late, then removing the breast was very morbid, and radiotherapy was far less morbid than removing the breast with an extended radical mastectomy. So you could get a 62% 5-year survival with advanced disease by just using radiotherapy alone. And that aligned with Ferrari, and is very much against what William Halsted was speaking to. And some of you may know this poem, Dulce e decorum est pro patri mori. That was a poem written during the Second World War when they used chemicals to use as bombs, and the soldiers used to die. When they did the post-mortem, they saw that the lymph nodes were destroyed. Nitrogen mustard gas, and in Johns Hopkins in 1948, they started to use chemicals to treat lymphosarcoma. That's a type of blood cancer. So that actually started after the Second World War, and it has basically progressed significantly. So, and then, well, I don't see my other slides, but basically, you have surgery, you have hormonal treatment, you have chemotherapy, and then as mentioned, you have targeted therapy. But do not be surprised if the disease comes back, because literally you have that polyclonal tumor. It's not a single set of cells, so it won't, all of those cells won't respond the same way to your medication. So expect to do your follow-up, and if you get a recurrence, don't be surprised. The best thing to do is remove as much of that tumor as you possibly can. When that opportunity arises, take your treatment and make sure that you have your follow-up surveillance on an annual basis. As far as treatments are all complementary, they are not exclusive. Because physicians have imagined what is taking place, they have advanced the technology. But all of these treatments, you need to have proper evidence that they are functional. I think that's my last slide. Thank you very much.
Okay, thank you, Dr. Munroe. So we have had a very informative evening with the presentations by Doctors Margo and Doctors Locksley Munroe. And so we are sure there are a lot of questions, so we will give you an opportunity to place those questions in the chat. We would also open the, you can also open your mic, and we are very privileged. This looks like a Ragged Island connection with these physicians. We have our medical director, Dr. I'm sure you all can figure it out, the Moxie. So we know the Moxie, the Munroe, it's a strong Ragged Island connection, but we must be really proud of our, you know, physicians, our homegrown physicians. So we will ask our medical director to facilitate at this time, Dr. Moxie, any questions, so you can put them in the chat. We just want to give out one or two more prizes. Perhaps you've recently been diagnosed, and you found this session to be beneficial to give you that guidance, that support to carry on. So if you wish to, you can either send it privately, send me a private note, or, you know, if it doesn't matter, because we're here to help one another, you can place your name in the chat and we have a prize for you. So without further ado, Dr. Moxie, would you take it from here, please?
Absolutely. Good evening, everyone, and thank you, Dr. Munroe's, Dr. Locksley Munroe and Dr. Margo Munroe, who seem to not be able to catch us up on both spending the evening with us. We certainly appreciate that and the valuable information that you would have provided us in both your talks. So as our listening audience gets their questions into us, I'll kick it off by asking some questions. So Dr. Munroe, specifically, can you speak to your thoughts on why we have such a high incidence of breast cancer in our community, and in particular among young persons less than the age of 30? What are your thoughts on that? I mean, less than the age of 40, sorry.
Again, just to let you know that I shortened the presentation because I know there was a time limit. But when I came home in 1992, there was an African surgeon here by the name of Dr. Garrett, and he made the comment that a lot of his breast cancer patients were out of utero. And when I came back home in 92, that trend was maintained. And myself and Dr. Brendan Curtis, when I had the data, and Brendan Curtis presented at MAB conference, I think in 2004, that the incidence of breast cancer in young women in the Bahamas at that point was something like 11%, compared to, if you look at the incidence in America at that time, it was like 3%, and in Britain it was like 1.7%. So ours was like 10 times, or at least 3 times higher than those other jurisdictions. Dr. Hurley, along with Dr. Lund and Dr. Turnquist, they started a program of looking at Bracha Gene. And what was found out was that somewhere about 33% of our breast cancer patients actually have Bracha Gene mutation. It's a very high incidence in our population. And that explains to a large extent why it happens. The ongoing research or data collection has shown that it's family-based, and I have families out of Acklins, I have families from Eleuthera, from Andros, and as well as Bimini, where almost the entire family has cancers of some sort. Some of them have breast cancer, some have colonic cancer, but I think cancer is genetically based. And then also if you have a problem with obesity, and they try to blame obesity for it as well, although I don't know if that's really the case, because a lot of my breast cancer patients actually are normal, and I've looked at that as well. They have normal BMIs. So I'm not 100% convinced with that obesity thing. It may be, yes, but like I say, in reviewing my information, this is 29 years, that's more than a quarter century. Not every breast cancer patient is obese. So I think primarily it is based on our genetics, primarily why we have such a high incidence.
Thank you for that response. And as a follow-up question to that, you mentioned the Bracha gene. Who should get tested and why?
Well, primarily, well, the initial study tested only those who had breast cancer, and come to find out that's why you know that 33% of them were actually BRCA positive. And then they did a new study where they just made it into the general public. But here again is why it is so expensive, because the first patient I did a Bracha gene on was a 28-year-old whose mother had died at age 33 with breast cancer. She developed it at 28. And she had to do her Bracha gene, which turned out to be positive through Kelso Lab. She had to pay $3,000 out of pocket because the insurance company didn't pay for it. In today's world, to do a Bracha gene is somewhere around between $5,000 and $7,000. So that is not a test that can be easily done, but it certainly, if you know your BRCA status, it certainly allow your management to be that much more definitive. But that is a very expensive test to have done. It's a good thing to do, but I can tell you it's a very expensive thing as well. And insurance companies don't usually cover it.
Okay, great. For Dr. Margo Munroe, you'd indicated in your presentation that radiation can cause cancer. So why do we use radiation to help fight cancer, is a question being posed?
Actually, it's a very good question. The radiation that's used to treat cancers are used at what we consider to be safe doses that have not been associated with patients developing subsequent malignancies. Now, having said that, I have to contextualize it by saying any use of high-dose radiotherapy, there is going to be that risk. But when you're using it for therapeutic reasons with doses and over a course or a period of time that's already been tested over the years in clinical trial, the likelihood of developing cancer is that much more reduced. Now, when you're using it to treat childhood malignancies, the unfortunate truth is, if the child survives the malignancy, they're going to live long enough, that 15 to 20 years, where they are likely going to manifest with a subsequent malignancy. So there's the good and the bad. How does radiation cause cancer? It actually, trying to figure out the easiest way to explain this. What it does is it creates or disrupts how the cells reproduce, and it can actually interrupt the check mechanisms that control cellular growth. So cancer is abnormal or unchecked cellular growth, and radiation can disrupt that and thereby create cancer at a later date.
Okay, great. Very good. Thank you. Thank you very much for that response.
Okay.
For Dr. Munroe, can you please elaborate on what is the best imaging tools that we have available to us for a woman wanting to have a breast for screening purposes? Doctor, I guess either can take either Locksley or Margo Munroe.
Well, I would think that the mammogram right now is the best screening tool, because remember, a screening tool isn't just what is defined as the best with one criteria. A screening tool should be readily available to all those who are at risk. And see, a mammogram, this is October right now. I don't know how much they're giving you mammograms for, but normally it costs something like $120. That's affordable. But if you do this, if you do an MRI is very, very sensitive when it comes to detecting breast cancer. But when those machines first came out, an MRI cost something like $3,600. I mean, if you come with a bean down or you come with a grandstand, you have $3,600 every year to get your breast evaluated. You can afford to get a mammogram, which may not be as sensitive or specific as an MRI, but certainly if you have an abnormality and you've found an abnormality, your doctor examines you, they find the same thing, the mammogram can be very, very helpful because now you can do a directed biopsy. And that's primarily used in those who are like age 40 and above. Now, at a younger age than that, possibly a better screening tool for those young girls, and I'm saying girl, even though you might be 21 or 22, would be an ultrasound. Because again, as Dr. Margo said, radiation has its downside that it can cause cancer. So the last thing you want is if you have breast cancer at age 40, you do not want to start giving your daughter at 19 mammograms, because by the time she gets to 40, that's 20 years of being exposed to radiation. And you're going to see the side effect. You're going to see the downtrend from doing that mammogram. So if your child requires evaluation, an ultrasound is probably better. And here's where you may have to find some money to actually do an MRI on the child, rather than sending them to do a regular mammogram. Now, when you're talking about screening for metastatic disease, primarily in my head as a biochemist, the best way to screen for metastatic disease is using a PET-CT, because that's based on the metabolic behavior of the tumors, as opposed to what we used to use, titanium. That thing basically was based on inflammation. But with the PET-CT, it's based on the metabolism of the tumor. So it is a much more sensitive and specific tool than what would be a regular bone scan. So your screening tool depends on what is it you're trying to do. And remember, like I say, it is very, very important to be able to detect if you have recurrence of your tumor. It is very, very important that you should be able, anyone should be able to access your screening method. So it can't be too expensive. And PET-CTs is something around about $4,000 or so. If you gotta pay, if you pay into insurance, you can get it for like $1,250 or maybe $2,500 compared to your mammogram. So you don't want to be saying it's a screening tool. You have to specifically say what it is you're screening for.
Okay, great. Thank you very much. Go ahead, sorry.
So I agree with Dr. Locksley Munroe. Just a couple clarifications. So the radiation that's used for diagnostic imaging is going to be a lower dose radiation than that's typically used for therapeutic radiation. That's one thing. The other thing is for the high-risk woman, young woman especially, and this is going to tie into what we discussed previously about the Bracha gene. Those women would ideally benefit, yes, from the mammogram, but from also being screened with the MRIs. So one of the discussions that we've had this back and forth with the insurance, when we send patients in for an MRI, they want us to justify why. The truth is, we do have a group of women in the Bahamas that are deemed high risk. And so there has to be some provision made for these women to have MRIs as their screening preferred tool. That's one thing. And I do agree in terms of imaging, how it's transitioned over the years. PET-CT is really the ideal imaging tool because it is going to help with determining stage, but it's also a very useful prognostic way to follow patients after they've been treated, because it's a functional and a structural study.
Okay, great. Thank you very much. Dr. Locksley Munroe, what counsel would you provide to a patient who on examination has been advised that they have multiple cysts in the breast, have had numerous lumpectomies, all non-diagnostic and non-cancerous? What advice would you provide that patient in terms of how they should move forward? And in particular, this person in our audience is requesting, should they get surgery? Would you recommend surgery, double mastectomy?
But surgery is based on your evaluation. And see, a cyst, if you know what a cyst is from an anatomic standpoint or pathologic standpoint, a cyst is a collection of fluid in an epithelial line, deformity primarily. Now, the best way to look at a cyst is using an ultrasound. Not so much the mammogram. The ultrasound is the best way to look at it. And one of the things we always look at is, one, are there any septation in that cyst? In other words, if that isn't just like a balloon that's blown up with air, if you see anything inside that cyst, that makes it that much more suspicious. If you see any sediments in it, you have to start worrying over that. Okay? But if it is just plain cysts, then you can watch those, you can monitor those. They don't have to be operated on, particularly if you operate on them once or twice, because, and I'll tell you why that happens. You may have multiple small cysts next to each other that is interpreted as being one cyst with septation. But when you've done the excision, the pathologist sends you back a report that says this is a mass that has multiple cysts in it. So that's what the septations were. It wasn't malignant. So if you come back with a similar kind of report, I would tend to watch that. And when I say watch it, instead of seeing you on an annual basis, I would see you 3 months for examination. And 6 months, I'd probably repeat that ultrasound. Why the examination? And I would teach you how to do your breast self-examination. See, one thing about cancer, cancers will always grow. So if you have a lump that is malignant, and I see you today, and then I see you in December, the lump today is 0.75 centimeters. And when I see you in December, it's 1.5. And then I see you in March and it's 2 centimeters. That is very, very suspicious. If that thing remains the same size, or if you say to me, because you can do your breast self-examination, well, sometimes it's big and sometimes it's small. That is in relationship to your menstrual cycle, your hormones going up and down. So again, cancers won't go down. Cancers will never go down. Cancers only get bigger and bigger and bigger. So if your tumor, if your swelling come and go, then you can watch it. If that thing is getting bigger and bigger and bigger, pay attention to it. So it's not just the cyst by itself. Yes, you may biopsy it because they give you this idea that it has septation or it has some kind of concretion or something within the cyst. That makes it suspicious. But if it's just a plain cyst, you can aspirate it and send that fluid off, depending on how it looks, or you can just watch it. But if that thing is getting bigger and bigger, then you have to pay attention to it seriously. That's what cancers do. They just grow.
All right, thank you very much. Dr. Margo Munroe. Who decides or how is the decision made on who needs chemotherapy alone versus chemotherapy and radiation?
Good question. It's going to be dependent on the size of the tumor. So the medical oncologist, they look at whether the lesion is a centimeter or larger than a centimeter, really. So there are a number of factors that we look at: the size of the lesion, whether there are any lymph nodes are involved, and how many lymph nodes. We also want to know if the lesion, when it was excised, how close was the edge of the cancer, the tumor, the swelling, the lump, meaning the same thing, to the resected margin. We also want to know whether there was any evidence of, how many lymph nodes, the size of the lymph nodes, was there any breach of the lymph node capsule? What that means is the tumor has broken through the lymph node capsule and is starting to spread locally into the surrounding tissue. Then the other thing we want to look at is, has the cancer spread and to where has it spread? So you have local spread, and that can be to the lymph nodes in the armpit, the lymph nodes behind the collarbone, and the lymph nodes on the side of the breast bone of the breast that's involved. So we would consider those local regional lymph node involvement. And then the other thing we want to know is, has the cancer moved to distant sites? Now, breast cancer likes to go to brain, bone, liver, and lung. It can go anywhere, but those are the 4 sites that it particularly tends to metastasize or spread to. So if a cancer has spread to distant sites, systemic therapy is the preferred management. And I will qualify that. If the cancer is in the brain, then the rationale would be to offer whole brain palliative radiation to get control of the center where you're thinking and you're making your rational decision. So control the disease in the brain first, and then the patient moves on to chemotherapy. If the patient has cancer that has spread to the bone, they can get the systemic therapy. But if the bone pain is unmanageable, so they're taking any number of pain medications, but they're still getting horrible pain that's disruptive of their daily activities, then we can see them to offer them palliative radiation to the painful bony site. So that's dealing with a patient that has stage 4 cancer, who is, because they have systemic disease, requiring systemic therapy. But if they have a particular site that's involved, then palliative radiation can be used to target those particularly painful or disruptive sites. If a patient has lymph nodes involved, but no distant metastases, chemotherapy is traditionally given first. So chemotherapy can be given as neoadjuvant therapy. That's going to be given to try and shrink the tumor if it's a particularly large tumor in the breast or lymph nodes that are involved. The chemotherapy can be given first, followed by the surgery. But once there are lymph nodes involved, radiation is typically also added. So those are typically the scenarios in which we would be looking at combining chemotherapy and radiation.
Okay, great, thank you. Dr. Locksley Munroe. So we'll take probably 1 or 2 more questions. So if you have anything that you want to have asked to our distinguished panel, please go ahead and put it in as soon as possible before we conclude the session. For you, Dr. Locksley Munroe, can you speak to your experience on how common is it, or can this occur where you have a patient who's been very diligent with doing their screening mammograms on an annual basis, and then suddenly being diagnosed with stage 4 breast cancer? Is that, 1, something that you've seen that can occur? And 2, how common does that happen? And give your thoughts on that.
Actually, that is something that I have seen. And I've seen it in any number of patients. Breast cancer has taught me many lessons. I've had patients, and that's why you see put that there about complexion growth for tumor. And even when you think you have a stage 1, and that is why I argue for PET CT from 2006 when people didn't believe in PET CTs, right? Because even when you have a stage 1, as they mentioned, 10 to 15% of those, even before you understand what's going on fully, they have already metastasized. So your 10-year survival, I know they use 5 years nowadays, would be like 85 to 90% in your stage 1, because 10 to 15% of your stage 1 cancer patients are going to die from disease. And I had that experience. I remember there was an old lady, did very well. And then one day she called me to say that she wasn't feeling well. When I saw that lady, she was jaundiced, she was having pain, and I was in shock. How can this be that this lady has a stage 1 breast cancer? She did a mastectomy, she taken out the tamoxifen, and she has liver and bone mets. And that is when it really comes to you, the whole business of the biology of those tumors and that Gompertzian calculation that tells you that basically those things really are growing very, very rapidly before you can detect them clinically. So that lady was a shocker like that. I had another young lady. She was like 38, or no, she was 34. She did everything again. And about 18 months later, she started complaining of headaches. And when we did the CT scan on that lady, she had brain mets. She did a chemotherapy, but as Dr. Margo mentioned, see, you have the blood-brain barrier. So those chemotherapeutic agents doesn't cross that blood-brain barrier so easily. So even though she didn't have any mets anywhere else, that thing had gone into her brain and the chemotherapy couldn't touch it. So 18 months later, she presented with brain mets. So yeah, I've seen it in persons who have missed their annual mammogram. I just had 2 patients like that. One of them got sick because she had an ectopic pregnancy. So she didn't get a mammogram and she ought to have. And by the time I saw her, she had nodes on the arm and she had stage 3 breast cancer just by missing 1 year. And again, to come right down to the basics, I mentioned sensitivity and specificity of any test. Mammogram have a certain sensitivity and certain specificity in detecting breast cancer, and you have to be aware of that. And that's why in many instances, the radiologist will tell you they want to use an ultrasound to go along with the mammogram to improve the specificity and sensitivity of the imaging. So there is no perfection in any of those things. And that is why it becomes important, if you have a question, to keep that patient under close surveillance. Because as I mentioned before, the tumor isn't going to actually stay one size. It's going to get larger and larger. So if you are clinically assessing that patient and sending them to get their imaging studies, you're going to see a change in the size of that mass, and then you know you have to act. So there isn't any particular test that is exclusive. They are all inclusive. They are complementary. You should be using all of them. You use your head, use all of those tests, because that thing can be very, very subtle, extremely subtle.
Okay, great, thank you. And so I think just to bring this session, this part of the session to a close, Doctor, I would like in the last, just a minute for each of you, some final closing words on what is the take-home message that you want to leave with our listening audience tonight. We'll start with you, Dr. Margo Munroe.
Well, thank you very much. I think one of the things I would like to share with everyone listening is that for any number of cancers, they have been converted to essentially chronic illnesses. So I draw reference to one of Dr. Locksley's slides, which was cure versus control. And so nobody wants to get cancer, but if you happen to have been diagnosed with it, most people don't get diagnosed and die the next day. That's typically not what happens with all the advancements that have taken place. Cancer research and findings have advanced to the point where we're now really doing tailored or concierge care of patients. Unfortunately, for a lot of patients in the public sector, they're not in a position to access all the specialized testings needed so that they can be given the right set of treatments specific to their particular cancers. So if I was to conclude, I would say it can be managed, and most cancers are now being converted to chronic illnesses. So if it progresses, you get changed to something else. So I don't think it's anything anyone should be afraid of. You just have to deal with it. Thank you very much.
Thank you. And Dr. Munroe, you have the Locksley Munroe, you have the last word.
Well, my main thing is that you should know your body. Get to know your body in detail. Go and see a doctor. The doctor doesn't know your body, you do. The doctor has the ability and the capacity to clarify what is it you are saying to him. And don't stop. Don't let that doctor tell you there isn't anything wrong with you when you have actually found something abnormal. I had a classmate that she was at Mount Sinai in New York. She felt something in her breast. The doctor, Mount Sinai is one of the top cancer centers in the US. They told her there wasn't anything wrong until she went back home to Jamaica. The guy who taught me about radiology, he actually did a funny mammogram run, detected, then she went back. They did all her service free of charge. So know your body and have the confidence to not let any doctor tell you there isn't anything wrong with you when you have felt something, okay? The next thing is, Kubler-Ross talk about grief. Do not go into denial. Do not go into denial. And again, a lot of my patients can tell you, I just tell them the 2030 Psalm. Even if you're walking through the valley of the shadow of death, if you have that information, walk it. Because guess what, as Dr. Margo said, who says you're going to die tomorrow? No. If you deal with that problem without delay, even though you don't know where it is you're going, right? I'm not taking you down there because I want to carry you there. It's because that's where it should go. But take that walk. Do not go into denial. Do not delay your treatment. And you'd be surprised. I have patients with stage 3 cancers who 20 years later, they are still here because they did all that was asked of them. They did their surgery, they did their chemo, they did their radiation, and 20, 21 years later, they're still hailing me. Sometimes I don't remember them all the while, never mind, but they're still here. Okay, so my main thing is to know your body, do not go into denial, and you cause your doctor to do what the doctor can do. They know what to do. But if they tell you that there's anything wrong, don't believe that. You tell them you want to clarify, okay, because it's your health at the end of the day. So know your body and follow through with what is going to tell you what's happening. Thank you. Thank you, Michelle.
All right. Thank you very much, Dr. Locksley Munroe and Dr. Margo Munroe. I will now hand the session over to Ms. Charlene Rogers to close us out and to give our, I guess, final vote of thanks to both of our presenters and our viewing audience for the evening. Ms. Rogers.
Okay, thank you, Dr. Moxley. Actually, we have Nurse Danishka Moss, manager of our clinical care department, who will do the vote of thanks. I just noted we may have had 2 persons. I don't see the hands anymore, but I'm hoping that your questions were answered. If not, you can still leave it in chat. We'd get back to you. Nurse Moss, would you please move with the vote of thanks?
Good night. Good night. I want to extend a very warm gratitude to Dr. Margo Munroe and Dr. Locksley Munroe. Your presentation was very informative and very timely as we observe the month of breast cancer. And to our viewing audience, we want to extend our gratitude to you as well. And we look forward to having you next month for another session of Doc Talk as we invite Dr. Christine Curler-Parker and Dr. Adrienne Davis, who will discuss diabetes. So we look forward to seeing you, ladies and gentlemen. A pleasant good evening.